Good morning. I've tried my best to simplify the pathogenesis of gallstones. It need not be that intricate. I try to make it as simple as possible, and I try to squeeze in a lot of clinical information also into the pathogenesis here and there so that it's much more interesting to read about the pathogenesis of gallstones. A few clinical fallouts which are relevant in pathology in the sphincter of OD, etc. I also highlighted. As is usual, all these images are from my personal collection, but in case I've taken some slide or endoscopy finding, I've given due credit to that particular facility or the particular doctor. So here goes. So this is about pathogenesis of gallstones. I find many questions about cholecystitis, all right, but about pathogenesis also coming in. So there's a bit of lot of physiology, not bit, lot of physiology involved in this formation of gallstones. So I'll be touching on them. Gallstones are the most common biliary pathology, and they can be asymptomatic in the majority of cases. This is also one of the MCQs. 1 to 2% of asymptomatic patients will ultimately develop symptoms. And sometimes the symptoms can be so severe, like a pancreatitis or a cholangitis, and can be really fatal also. Anyway, we are not going to go into the clinical aspects of gallstones. We are going to stick to the pathogenesis of gallstones today. So let's have a look. It has very high incidence in the North America. India has a moderate incidence only, but it has got very high incidence in the American continent, somewhere a little bit in Europe, and India has moderate, but you hardly find it in these Southeast Asian, other Oriental countries. We don't know the exact reason. In India, you need to know that there is a belt. It's very common in this belt. It's also getting commoner down south. But traditionally, if they ask you, the incidence is far higher here. So now we will see what is the difference between the hepatic bile, the bile in the hepatic ducts, and the bile in the gallbladder. This is quite important from the physiological point of view. The hepatic bile is isotonic and an electrolyte composition resembling blood. Hepatic bile is concentrated within, then the hepatic bile reaches the gallbladder and gets concentrated by the absorption of water, which is an energy dependent process. The whole bile acid pool can be sequestrated in an overnight fast. When you're fasting, naturally the bile will not deploy into the duodenum. So the whole bile acid pool will be sequestered in the gallbladder. The capacity is 30 to 50 ml. The electrolyte composition of gallbladder bile differs from that of hepatic bile because most of the inorganic, as you know, there are some absorptions happening here. So the bile coming out here is a little different from the bile in this area. This is an important physiological point to be remembered and also clinical. We'll come to it later. So the electrolytes and other things have got absorbed. So we said when the bile remains long enough in the gallbladder, everything gets absorbed. So what happens, not everything, the water and other electrolytes will get absorbed, including the pigments, they get absorbed. So now let's have a scenario. Suppose there is something blocking here. Say there is a stone which has blocked the cystic duct. Now we are not talking about stone in the CBD. It will produce other symptoms. But we are only talking about a stone blocking the cystic duct, like the way you see here. Practical applications. Short cystic duct, it went and got impacted. So all the electrolytes, everything got absorbed through the gallbladder epithelium, including the bile pigments. So what you have a mucocele of the gallbladder. When you try to aspirate this gallbladder, because it was big enough and for ease of surgery, when you try to aspirate, you will get a typical white bile. So this is known as mucocele of the gallbladder. Not all the time you will get an exact milky white bile. Sometimes you can just get it mildly greenish yellow tinge, but you can see by and large it is mucus there. Next, there is biliary loss. The biliary loss has, if it is in the hepatic ducts, this bile will contain more electrolytes. These electrolytes will get absorbed in the gallbladder. So for some reason, there is a fistula here, either iatrogenic or a disease process or because of trauma. Patient who loses bile here will lose more electrolytes than a patient who's losing bile here. This is applied physiology. Suppose same thing, trauma, iatrogenic, malignancy, whatever. If the bile loss is from here, the electrolytes will be less. Not only that, if you look at it from an anatomical standpoint, if you have a problem here, it is much more difficult to reconstruct than a problem here. So that is your applied anatomy and your applied physiology. But by and large, in day-to-day practice, a bile loss is a bile loss. It is not a great difference in your clinical management. Clinical management will be about the bile loss only. We will not break our heads about the exact electrolyte concentration in this part of the bile and this part of the bile for you to treat the patient. So these are the practical applications. There's something known as normal physiology, abnormal physiology, and acceptable physiology. You cannot push your own labor into finding out what exactly is the clinical electrolyte loss in this bile and the clinical electrolyte loss in this bile. But you need to know the differences from a physiological standpoint. Now, you know bile is 82%. This is the bile. We are talking about composition of the bile. This is the bile. We are talking about the composition. It is water, bile acids, lecithin, and unesterified cholesterol. Now you see the composition of cholesterol is only 0.7%. But you need this much of help to keep it in the dispersed or soluble form. And especially the contribution from bile acids. This is very important. And of course, you have a other lot of hitchhikers also there in the bile. So the main villain is the cholesterol. These two are your safeguards from cholesterol precipitating in the medium, which is your water. What are bile acids? They are primary bile acids, cholic acid and chenodeoxycholic acid. Secondary acids develop in the colon and they do have a role in physiology. So as I told you, cholesterol is central. Around that there is a lipid layer, which is your bile salts and your phospholipids. And then you have these outliers. So this cholesterol is water insoluble. We have told this again and again. To keep it in balance, you need this second layer of bile salts and phospholipids. Now, if there is excess cholesterol, it will precipitate. What about bile acids? They are basically detergents. And they make molecular aggregates called micelles. Since cholesterol is poorly soluble, it depends on the bile acids. So normal ratio of these constituents favor the formation of solubilizing mixed micelles. You know the normal concentration I've told in the previous slide. they allow it for the cholesterol to be solubilized. So the primary bile acids, again, it's the same which I'm repeating. You need to know about the bile acids. They have a very big important role to play, especially in the clinical part. Not much so much as phospholipids, which also help in this second lipid layer for the cholesterol. So now let's have three scenarios. You have increased cholesterol, but normal bile acids and normal lecithin. I don't think there is any clinical situation where lecithin is low or high. So it doesn't even come under the equation now. If it is high but normal bile acids, normal cholesterol but low bile acids, both cholesterol is low and bile acids, cholesterol is high and bile acids have come down. These are the conditions which will lead to supersaturation of your cholesterol. Then this supersaturation just like that will not go down the line. It needs some help to promote nucleation from various glycoproteins. Similarly, other group of proteins will inhibit this supersaturation. So there are checks in this step. Whereas if it crosses and goes here in spite of no balance here, or in spite of these two trying to balance but still balance is lost, once it goes into the nucleation stage, there are no checks and balances. Automatically it will go into the microstone and finally into the gallstone itself. Microstones are very tiny stones. Sometimes they are not even visible to the eye. So ultimately, it's a balance between cholesterol, phospholipids, and bile acids. Again, you see when this is a graph when the cholesterol is going up, or the bile acids are decreasing, or for some reason lecithin concentration is decreased, you will start pushing this bile as lithogenic bile. They will ultimately form stones. So in this part of the diagram, the bile starts getting more and more lithogenic and then forming the stones. Now this your physiology comes in. Is it only to do with the chemical composition of your bile? No, there is a fair amount of physiology also. What happens? The sphincter of OD is an important area. You'll know about it. It's a common channel for both pancreatic and bile duct. Sometimes, of course, the ducts can open separately. That is anatomy. It is always in a tonic state, so that one, it will prevent reflux of food into these two ducts. Some food is there, it will enter these two ducts. Your food has a lot of bacteria. And these are basically ductal structures which don't have bacteria inside. The food will enter and cause cholangitis or pancreatitis. So you have this sphincter in a tonic state. Not only that, it allows the gallbladder to be distended when there are no meal times, and the gallbladder will be doing its action of concentrating the bile. Now, what acts on this sphincter? You have the hormone, which is your cholecystokinin, that is released when food comes into the duodenum in response to fats and amino acids, not your starch. It causes powerful contraction of the gallbladder. It decreases the resistance of sphincter of OD, and it also by an unknown mechanism will produce more secretion of bile. All this will add up to more bile entering when there is a fatty meal or a highly protein meal entering the duodenum. Let's imagine a scenario. A cholecystectomy has been done, and either the cystic duct which you ligated is having an issue, or there is some injury to the CBD usually, or to the higher ducts. There is some injury. Now, how do you tackle this? This will be constantly under your sphincter of OD will be constantly under a tonic state. It won't open up easily. So since there is a lot of resistance, this bile leak will start leaking into the abdomen or into the surface if a drain has been kept. So it will continue to leak. Your gallbladder is out. What can you do? You can do an ERCP. Put in an endoscope, cannulate this. You see this is the ampulla, that elevation there. Through that one small opening, you put a guide wire and then you put the tube across and push in some dye first. Don't be in a hurry. When you push in a dye, you will see the whole CBD and the extrahepatic ducts lighting up. This is your fluoroscopy now. This is endoscopy. By the side, you have a fluoroscopy screen also. Not only that, it has shown a small leak from the cystic duct stump. Probably the cystic stump, which was clipped, has opened up. Doesn't matter. Now what you do, once you find there is an injury here, try and cannulate and open and keep that tube there so that this sphincter will remain open. There will be less resistance and your biliary leak outside or into the abdomen will slowly stop. Then you can look at how well to manage the injury if at all it needs a repair now. So where are we? We have done a cholangiogram. We have found out the leak. And then what you do a sphincterotomy. You cannot push in a stent just like that. You put in a guide wire to do a cholangiogram. But you cannot put a stent through that small opening. You need to make a sphincterotomy. You can see that the sphincter here, it has got enlarged. Once you do that, you can push a hepatic stent. That size will depend. You can put a stent inside. Ultimately, your stent will go beyond the injury and lodge in the right hepatic duct. If you drain one segment of the liver, one lobe of the liver itself is good enough. The resistance will come down. Not that you must put a double stent into the right lobe and the left lobe. That we'll come to it later. There are situations when you do double stenting. So this is your hepatic stent. Fine. After some time, he might need a surgery itself. Or the whole bile leak, if you do a cholangiogram, you find it has stopped. You can even remove the stent. So that is, I wanted to take you through this ERCP and hepatic stenting. So ultrasound of the gallbladder, this is the liver, this is your gallbladder, fundus and the neck. Now when it is distended, it will have a certain size. When it is contracted, you can see it here. It is distended when you do overnight fasting. There is no food in the duodenum to release cholecystokinin. So it will be distended. That is why gallstones or anything in the liver, you want to see the gallbladder especially, you ask for an overnight fasting from the patient whenever possible. And then you see the contracted gallbladder, the volume has come down. This is after a meal. Or you give cholecystokinin and see whether the contractions are good enough. As we were talking about cholesterol, you also need to know that there may be situations when bile acids are low. The cholesterol is normal, but the amount of bile salts or the bile acid pool is very low. So what happens? When should bile acid be low? When your significant length of small bowel is lost. We are not talking about large bowel, small bowel is lost. Large bowel has a role in the making of secondary bile acids. But small bowel absorbs most of the bile acids and takes it to the main pool. If it is less, because the small bowel is having a disease or the small bowel has been resected for various reasons. Now, even if the cholesterol is very high, still patients do not get stones. Not all of them land up with stones. So is there something else working in the pathogenesis? As I told you, there are pronucleating and nucleating factors, but is there something else working? As I told you, cholesterol, phospholipids, where do you get hypersecretion and in obesity and oral contraceptive pills, reduced bile acid pool in your short bowel syndrome or in your ileocolic anastomosis. For some reason, you have taken the ileum and anastomose to the colon. The ileocecal valve is obviously not there. So the ileal transit will be very shortened, and where your bile is absorbed, that time will be shortened. So your bile acid pool will come down in those situations. What are the types? They can be divided into cholesterol, pigment, and mixed stones. Let's talk about cholesterol. In 80% in Europe, the West, it is cholesterol or mixed, and in the Asian population, it is pigment stones. However, both of them will contain cholesterol. Depending on whether they are pigmented or pure cholesterol, the concentration of cholesterol will, the proportion of cholesterol will go up. So as I told you, once it goes into the nucleation phase, there are no checks and balances, and it will rapidly go into the stone phase. So this is your timeline of gallstone formation. We were talking about this cholesterol and bile acids. Is there something else working? I had mentioned that hypercholesterol itself, not all patients will get gallstones. So there is something else with the motility itself. They exhibit abnormalities of gallbladder emptying. Show that gallbladder patients have an increased gallbladder volume during fasting and also after a test meal, and that fractional emptying after gallbladder stimulation is decreased. There are patients whose bile are okay, but they have an hypomotility disorders. So gallbladder emptying is a major determinant of gallstone recurrence. In patients who underwent biliary lithotripsy, you did not remove the gallbladder, you only did a lithotripsy. You gave shock waves from outside and removed the stones. Now, if they are recurring, then they have a problem with the gallbladder emptying. How can you measure gallbladder mobility? Your radioisotope. We will not go into the details. Number 2, your gallbladder volume by USG. They have a mathematical formulation to decide the residual volume after a meal. So now we talked about supersaturation of cholesterol. We talked about bile acids are less. We talked about how nucleation is the rate limiting step, finally forming crystals. Now you have introduced another concept, which is your hypomotility. Fine. And finally you form a crystals and gallstone. Now, where exactly these chemicals are acting? The nucleation, everything is happening in this mucus gel layer. Now, they will not sit there quietly forming stones. They will start eroding the mucosa. That is what has happened. Chronic inflammation. In fact, they have even eroded the mucosa. In one place, you can see the gap. There is only serosa there. So they start acting on the rest of the gallbladder. Not only that, they'll produce severe thickening of the wall. Actually, there is inflammation, thickening of the wall, and hypertrophy of the muscularis mucosae. So now gallstones can be cholesterol stones or pigmented stones. So this is the stone, and these are the outliers now. Previously, it was cholesterol, bile salts, and lecithin. Now, your bilirubin and your calcium salts and bilirubin, they will all happily get into they will hitchhike onto the stone now. Okay, we're talking about pigment stones. We are not talking about mixed stones. We are talking about pigment stones. Pigment stones, they contain less than 30% cholesterol. They are insoluble bilirubin pigment polymer and calcium phosphate and bicarbonates. 20 to 30% of the stones are black. They are usually found in hemolytic anemias, and cirrhosis for some reason has a high incidence of black stones. Coming to brown stones, they have calcium bilirubinate, calcium palmitate, stearate plus cholesterol. They are, one important thing, they are rare in the gallbladder. They form in the bile duct, which is already infected. So the villain is not the gallbladder there, which is already infected, or you have stents there, which are foreign bodies, or you have parasites in the biliary tract. So they form there. This patient which I shown, he didn't have a brown stone, but I'm telling you this is the biliary stent, which is your endoscopic view. And this is your biliary stent finally when you confirm with your fluoroscopy. So I've covered a little bit about ERCP and biliary stenting. So now, after having talked about all these gallstones, the question is how many of them are radiopaque? It's a common question. It's about 10%. And you're lucky to spot them on a plain X-ray. But then what you need to know, how do you differentiate gallstones from a kidney stone? They will be usually placed near the 9th costal cartilage. Number one. Number two, kidney will be medial. Number two, if you have a closer look, the stones will be faceted, like here. You can zoom in and you can see that these stones are faceted, or at least you can imagine they are faceted. So this is as far as the pathology part is concerned, the histopathology. As I told you, the stones, when they stay there, they keep on irritating the mucosa and it gets chronically inflamed. In fact, sometimes the mucosa can even denude off and you're just left to the serosa there. What do you find in, and you can see this thickened wall. What do you find in histopathology? You find the broken mucosa. See, they are broken everywhere. Number two, there are these sinuses. This is another question which repeatedly comes in your MCQs. And then you have the hypertrophied muscularis propria. See, that is leading to the thickness of the gallbladder wall. So finally, gallstones are common, but usually asymptomatic. Now what happens, especially when you do master health checkup, pregnancy, antenatal scans, invariably they'll have a gallstone picked up, for which the patient will be asymptomatic. We are not going to go into the pros and cons of operating and not operating on a gallstone which is asymptomatic. That is for a later discussion. Now, gallstone disease is more common in some areas, like in the world. The American continent, especially South America, it's very common. India has a moderate incidence, and in India, the northern belt has a high incidence. The pathogenesis is always an interplay. All along we talked about cholesterol, phospholipids, bile acids, but now ultimately we are going to talk about the motility of the gallbladder also matters. So thank you so much, and please do share. There will be a series of questions on gallbladder pathogenesis, on gallstone pathogenesis in my Telegram channel in the coming few days. So please share it with your friends too. Thank you.